we have some very prominent names who are actually going to be the speakers for tonight. We have Dr. Rajendra Prasad, who will be talking about COACT, post-cataract surgery. We have Dr. Quresh Muscati, who will be talking about resistance to resistance, choosing the right antibiotic. And also Dr. Sangwan was supposed to talk about dry eye inflammatory dry eye. Unfortunately, he could not make it. His mother is not well. So I'd like to first invite Dr. Quresh Muscati to also join the panel. He's been conferred the prestigious honorary FACO award by AIOS. Super specializes in diseases of cornea and anterior segment. Has over 24 scientific publications to his name. Co-author of chapters in ophthalmology in over a dozen books. Was former president of Maharashtra Ophthalmic Society, Bombay Ophthalmologist Association, and also former president of AIS and the Cornea Society of India. Welcome, sir. And last but not the least, we have with us our very own Dr. Rajendra Prasad. He'll be our first speaker. He's currently the director of RPI Institute and Research Center. Has been awarded several medals, including the most prestigious National Innovator Award in 2018, the IRSI Gold Medal Award in 2017, UPSOS and UKSOS Gold 2017, and also the ACON Gold 2015 in recognition of scientific contribution and dedication towards advancement in cataract and refractive surgery in ophthalmology. He's also currently the Vice President of Delhi Ophthalmology Society and has several innovations to his name. I welcome you, sir. Please take the chair. So the first topic is COACT, managing the cataract surgery, and Dr. Rajendra Prasad will be our first speaker. Do we have the slides?
Good evening, friends, ladies and gentlemen, panelists and chairpersons, Dr. Mahipal, Dr. Bharti, Dr. Rishi Mohan, and Dr. Muscati. And I thank you, first of all, I thank Allergan for bringing me here in this beautiful evening with all of you. And the topic which I'm going to talk about is 6/6 vision in challenging cataract surgery cases. So I'll take up a few important cases, difficult cases, where we finally landed up with the 6/6 vision. So that is the idea of this topic. The first case which I'm going to take up is the pediatric cataract, a 3-year-old child who came up with the bilateral cataract of this sort, what you can see here in the picture. The main challenges in this particular case were the timing of surgery, capsulorhexis, whether to go with the primary capsulorhexis PCC or do an anterior vitrectomy or not. And IOL selection was very important in this particular case. IOL placement, where to place the IOL, and wound closure with suture or not with the suture. So we'll just go through the video. So you can see that I've made the side port incision and staining the anterior capsule. That's very important because the capsule is generally very elastic. So one has to be very careful in doing the capsulorhexis. The capsular tear extension is very common with these children. So your centripetal force has to be more than the centrifugal force. So you have to just tear the capsule and bring it towards the center. Your forces should be towards the center, and you can see the anterior capsulorhexis is complete. The cataract won't be very, very difficult to remove in these children because cataract would be just very soft cataract. And in this particular case, there was some calcification also in the nucleus. So we have completed the removal of the the complete cortical, epinucleus, and nuclear complex of the cataract. Now coming to the PCC, which is very, very important because since this child is 3 years old, so we have planned to go ahead with the PCC. The PCC is not very difficult because the posterior capsule in these cases is manageable, unlike the anterior capsule. So you have to be careful, without disturbing the vitreous phase, possibly. You start, again, your forces should be towards the center. Go very slow, don't be very fast in making the PCC. And it should be of a size smaller than the anterior capsular axis. And as you can see here, I'm trying to pull it towards the center, but normally the forces what you apply, it results into the more effect. So as you can see, because now we have planned to do the anterior vitrectomy also, a partial anterior vitrectomy, what you can see here. So you have to do a very little vitrectomy, don't go very deep, a little bit of vitrectomy. And once the vitrectomy is complete, you can see the anterior capsular axis and the posterior capsular axis beautifully coinciding. And then we plan to put in the IOL. In this particular case, what I'm doing is I'm putting the IOL into the capsular bag. So this is what we have planned. And the leading haptic has to go within the capsular bag, and then you can dial or knock the trailing haptic into the capsular bag. The wound closure is very important because the sclera is very elastic. So it's always better to put a stitch in pediatric cataract so that you have a tight wound. And once you complete the wound closure, so in this particular case, we plan to do the iridectomy also. So I'm doing the vitrectomy probe-induced iridectomy. So it's also very important in pediatric cases. You do iridectomy because many of these cases would land up with the pupillary block glaucoma or other sort of glaucoma. So it's important to do the iridectomy. And then finally, what you have to be sure, like your pupillary area is clear from the vitreous if anything is there. So do a cleanup of the pupillary area and the anterior chamber with the vitrectomy. So this is what I have done here, completed. And as you can see, the surgery was completed. This child had a 6/9 vision with +1 diopter sphere, approximately a month later of the surgery. So this was the first case. So the important point which you need to look into the pediatric cataract is the primary PCC with anterior vitrectomy for children, those who are less than 6 to 7 years of age. Primary PCC without anterior vitrectomy for the children, those who are more than 7 years of age. And PC left intact in children, those who are above 9 to 10 years of age. This is very important. So this is how you have to go with these cases. And posterior capsular axis plus anterior vitrectomy, what are the advantages? If you are doing the primary posterior capsular axis, then the disadvantage would be the very high rate of opacification of anterior vitreous phase in smaller children, because if you do not do the anterior vitrectomy. And if you do the vitrectomy, then you have a chances of vitreous phase disturbance. So this could induce some sort of inflammation in the anterior chamber and the vitreous cavity, and we may land up with the cystoid macular edema. So you have to be very careful in doing the anterior vitrectomy. As I said in the beginning itself, do a very partial and limited vitrectomy. So I'll come to the next case. So next case is a classical posterior polar cataract, as you can see here, the onion peel kind of picture. Now this particular case which we confirmed, there was the PC defect also, a small PC defect. So the challenges in this particular case would be, most of these cases have a high incidence of intraoperative posterior capsular disruption is very, very common, and if the case is those who already have a inflammation and release prostaglandin and in both the way. So you have to use the combination of the topical NSAID and steroids for the control of the inflammation. You all know these are the commonly used corticosteroids and the commonly used NSAIDs. But the only problem is because all these medicines we use in the drop form, multi-dose drop form. So in any multi-dose drop forms, you have to put in the preservative also. So there is a preservative, and we use, these are the variety of preservatives used in all these medicines and the drop form. And the most commonly used is the BAC, that is benzyl cholium chloride. This is the most commonly used preservative in most of the drops. But this drug has a lot of disadvantages. And these disadvantages could be in the form of the patient may, in the form of it hampers the wound healing, the patient's comfort would go down, and the final visual recovery may be hampered. And so what is the alternative? So alternative is to find out a preservative which is tissue friendly. So there have been a lot of research on this, and these are the three alternative preservatives which have come up, and one of them is the purite. So this is one of the very simple and very tissue-friendly preservative which is being used now in many of the drops form. This is a stabilized oxychloro complex SOC, oxidative ophthalmic preservative. Now this actually component have the mixture of 99.5% chloride and 0.5% chlorate, a very trace amount of the chloride dioxide. This is a very good bactericidal, fungicidal, and virucidal properties, so that there won't be any contamination in the drop if you're using this preservative in the drops. And there has not been any documented toxicity to the mammalian cells also with this preservative. Does not induce any cellular damage. So your corneal damage or the tissue damage is not found even if you're using a prolonged use of this preservative. And this purite is generally, it's in the suspension formulated using micronized particles, also prevents the physical irritation or scratching of the cornea. So this preservative is very commonly used now, and especially it is used in a drug which one of the very commonly used NSAID is the Nepafenac. The Nepafenac uses purite as a preservative. And we know that Nepafenac is a prodrug. It is very highly lipophilic, and its corneal permeability is highest than any other NSAIDs. You can see here this graph, because the kind of the corneal permeability this drug has, other than, because we use bromphenic, diclofenac, but they have a very low permeability, and they use the BAC actually as a preservative. So this is the only drug which uses the purite as a preservative, and it has a very high penetration value into the cornea and controls inflammation very, very effectively. So this is how we, current cataract surgery recommended medication, pre-op and post-op. Pre-op, we use broad spectrum antibiotic along with it and NSAID at least 3 to 4 days before the surgery. Intra-op, we may or may not use intracameral antibiotics, but post-op, then definitely topical antibiotics, topical steroids, and topical NSAID. Because why I was talking about the purite is because when it comes to NSAID has to be used at least 1 to 2 months after the surgery. This is very, very important, because otherwise you have seen many of cases as coming with the CME, cystoid macular edema, and that is the only reason for that is because we are not using proper NSAID in these cases. So make sure that your NSAID from 3 to 4 days before the surgery, and it has to go on at least 1 to 2 months after the surgery. This is very, very important point. Steroids, you can manage accordingly, looking at the inflammation, and accordingly you can use the steroid and the antibiotics. Antibiotics generally should not be used more than 1 to 2 weeks. And with the tapering, you should not taper these antibiotics. You have to use steroids at least a month with the tapering doses. But NSAID is very, very important. So this is the schedule which we have been using. There are different methods of using these drugs into the eye. Finally, we'll come to the Conclusion, achieving quiet eye after cataract surgery is very, very important. Topical NSAIDs are used to control the inflammation and to achieve the quiet eye. However, preservatives present in the topical formulation can cause adverse effects. Among the preservative, BAC has been shown to cause tear film instability, loss of goblet cells, conjunctival squamous metaplasia and apoptosis, disruption of the corneal epithelial barrier, and damage to the deeper ocular tissue. This is very, very important. Puride is novel alternative to chemical preservatives, and topical NSAID with puride preservative may be useful to achieve the quiet eye. Thank you very much.
Rajendra Prasad for wonderful complicated cases videos which he is expert in. So that's absolutely informative videos how to manage all these complications. And we have a guest coming from outside Delhi. That's another wonderful thing to happen today evening. Quresh, you're welcome to Delhi. And so I'll ask one question, and I want to ask Quresh as to which post-cataract cases he wants to use prednisolone alone, and in which cases he wants to use prednisolone along with nepafenec, and why?
See, it's actually very, very surgeon dependent. The picture that Dr. Rajendra Prasad showed was Richard Lindstrom's landmark paper. This is 2011. We are now in 2022. Surgeries have become a little better. I mean, my surgery is going downhill, but most of the other surgeons are improving in their surgical skills. So the need is down. So with my surgery, I tend to use difluprednate. I know people don't like it, but I love difluprednate because I give it 4 times a day, and no matter how badly I've done the surgery, I get a fairly quiet eye. And I check the pressure the next day, and I check the pressure after 1 week. So both the times I'm checking the pressure. If that at next day and after 1 week the pressure has not risen, it's not likely to rise because I'm tapering it 4, 3, 2, 1, and in a month's time the difluprednate is stopped. So in a small percentage, maybe 5%, I get a pressure spike, in which case I will then switch to something lower. As far as the nepafenec is concerned, I seldom add it. What I do is, I'm tapering my difluprednate over a month. After that, the patient already has got that nepafenec which he had used pre-op. And in Mumbai and perhaps even in Delhi, people don't like to waste drugs. So that bottle is left over there. I tell them first, ignore what is written about throw away after 1 month. Kuch kharab nahi hota hai wo bottle. And then once the tapering is over, I then ask them to put that balanced nepafenec which is there with them 3 times a day till the bottle is over. So they love it because they say, bottle ka paisa vasool. So that is how I use for my uneventful cases. Whenever I have eventful cases, about 67% of the time, that is the time I will then combine the nepafenec and the difluprednate. Thanks to them.
So, thank you, Quresh. Thank you.
Dr. Bharti, I'll just wish to add, actually, when you're using prednisolone versus nepafenec or combination, so whenever there is a posterior segment issue that you're expecting or you're expecting post-cataract, CME, etc., so that's when you wish to, so diabetics or complicated surgery or anything where you are expecting a macular edema, that's the time when you need to look at nepafenec. Though there are studies which have shown, even studies have shown that even if you don't use anything, versus you use non-steroidal versus you use steroids, so there isn't much of a difference in the inflammation in good surgeries that have been done. But I would add nepafenec definitely in cases where I expect that these patients would possibly have a higher tendency to go towards macular edema.
Thank you. Thank you.
So as a corollary to that, I understand about the ocular comorbidities where one expects more inflammation, but I think both of you are experienced flax surgeons. Do you notice a difference in inflammation between conventional phacoemulsification and flax?
Definitely, you know, with the IOP changes during flax and also pupil getting smaller during flax and then, so in that cases, preoperative nepafenec is also of a great value because that is the way you can, getting the pupil down during the flax and after it, that takes care of that. And of course, as Quresh was mentioning, if you ever expect like diabetics or such patients, the posterior segment steroid is difluprednate. So that's another factor where I want to use difluprednate along with, of course, nepafenec, because that's the primary drug for pre-op and post-op for next 6 weeks or so.
But I don't find much of pupil coming down in liquid optic interface if you have already given a non-steroidal anti-inflammatory for maintenance of pupillary dilatation.
Yeah, that's right.
It's much
But-
less,
but
and
I-
the inflammation from a perspective of the phaco time going down, basically the amount of striate or whatever that you would get would be much less. So overall, I think as a routine, I'm finding the corneas to be clearer and maybe the inflammation to be a little less with the flax.
Definitely, if you do not use nepafenec before, I use it for 2 days, then the pupil definitely goes down during and after flex. Before doing phacoemulsification, after the laser, the pupil starts going down. So that's where I want to use in all those cases, definitely. And that's my protocol, yeah.
So if I had to take a quick poll from the audience, how many of us use nepafenec or any other NSAID routinely preoperatively? Post mein baad mein पूछूंगा. So that's still only half of us. All right, so it's probably more than half of us. So I think that has become the pretty much, I think, the standard of care. And amongst the panel, I would ask another question, which is how soon do you actually start preoperatively? 2 days, 1 day, 1 hour?
See, recommended is 3 days. It has to be 3 days minimum, because any NSAIDs, to have its actual action, it takes 48 hours. So a day before won't be, because if you are talking about the pupillary part and the retina part, it has to be 3 days before. So if you start 3 days before, then only it will have a final effect on the
Quresh,
body.
what's your practice? What do you normally do?
I used to do it 3 days before, but then I found compliance to be an issue. I used to put antibiotics and the nepafenec 3 days before. And then I found half of them were not doing it correctly. So now, supervised at my hospital, we just do it 2 hours before.
Okay.
And that seems to work, because I need it only for the limited purpose that I don't want the pupil to come down on me. And somehow with a combination of tropicacil and the plus and the nepafenec, I seldom get a pupil coming down. Even if it comes down, now you've got intracameral stuff which you can put in. So it's not so much of a bugbear.
So in my cases, in flax, I use it for 2 days. Also the antibiotic along with nepafenec. And for a normal MICS, I use it on the day itself, 3 times before shifting the patient, and every 15 minutes before shifting the patient to the OT.
Yeah. And that's CFS?
I do it only in the morning, and I think phenocaine availability has really made a significant difference. So pupil coming down is hardly an issue, I think, anymore.
All right, so thank you very much, Dr. RP. I think that's a very nice presentation and allowed us a good discussion as well. So I'm going to hand over to Dr. Mahipal to introduce Dr. Quresh. And
Quresh, our guest from Mumbai, we all know him, and apart from the introduction that was given, I think he is a master of wit and satire and humor. And over to you, Quresh. He'll be talking about resistance to resistance and choosing the right antibiotic in ocular infections.
Which is the point of this?
The other side.
Okay. It does work with me also. I don't have anything to press here, so somebody's going to... I suddenly found empty space vacuum here where a laptop used to be. So somebody will have to do it from there then. So when I say the word next, it means next slide.
Next speaker.
So I'm going to go a little quickly. We'll skip over some slides. This is a little boring subject because there's a lot of pharma in it, a lot of things about pharmacodynamics and pharmacokinetics. These are big words thrown at us. I'll try and simplify it as much as possible because there are certain key take-home messages that I want to leave you with. One is that antibiotic resistance is a global concern, and we as ophthalmologists or as medical people are contributing to this resistance because of our overuse and abuse of antibiotics. We flood every pink eye with the highest possible 4th generation fluoroquinolones. We give it prophylactically, we give it post-operatively, we give it in combination with steroids, and we really flood the patient's eyes. And all this has caused a lot of problems. Even the economics there is a problem. And the empirical use of, and there are two ways to use antibiotics. One is to pretend that we are Einstein or whatever, and when a patient comes to us, this looks like gram-negative Pseudomonas, and then we proceed with some antibiotic. Or the other way, which is to take a smear, then send it for culture, which seldom we do, though even we are in Mumbai, Delhi, where the facilities exist. I can understand smaller towns where it doesn't exist, but here we have it at our beck and call, and we don't use this. So we are contributing to antibiotic resistance in a big way. Next. Next. Do bar next below means next slide. So there are some words like MIC, minimum inhibitory concentration. We must understand a little bit about this, and then we junk it. Because what is minimum inhibitory concentration? What do? They take vials of the antibiotic and they keep diluting it. And they come to a minimum inhibitory concentration. There is MIC 50, MIC 90. So if it's, maybe kar sakta hu. Very good. So MIC 50 and MIC 90 means the minimum concentration of the antibiotic required to inhibit, minimum inhibitory. So to inhibit 50% of the organisms is MIC 50. MIC 90 therefore is to inhibit 90% of the organisms. So this was, MIC was used for many years or for decades as the only way to judge the efficacy of an antibiotic. So the lower the MIC, the lower the concentration required to achieve that 50% or 90%, the better the outcome or the better the antibiotic. So an antibiotic having a lower MIC is preferred. Higher MIC would therefore indicate a greater likelihood of clinical failure. अभी आप कुछ नहीं करना, मैं सीख गया हूँ. So after a long time, just like in antibiotics for 40-50 years, there was hardly any change. We had the 3rd generation, 4th generation of antibiotics of fluoroquinolones, and for a long period of time, nothing new came out. Similarly, in the pharma sector also, MIC ruled supreme for a long time, but it's now being replaced by mutant prevention concentration. And this is what we need to know. MPC, I'll explain this. MPC is typically about 10 times MIC. That means MIC only inhibits the minimum dose required to inhibit. The MPC is the higher dose, 10 times the dose which is required to not only inhibit but to prevent mutation. So it inhibits, it kills all the bacteria and it prevents mutation of the bacteria. So it's that higher dose, usually 10 times the MIC. So it prevents the growth of mutant subpopulations and it requires higher drug concentrations. So this graph very well explains it. So, so this first lowest red line that you can see is the MIC concentration. So over here, if you give a drug which is below MIC, then the bacteria love it because they're going to thrive. If you give above MIC, there is no growth because you have inhibited. You're higher than MIC, so you have inhibited. But the bacteria are alive and they can mutate therefore. However, if you give MPC level, then there is bacterial death also and no mutation. So this is the area, this is the top, this top part over here, this is the area under the curve, this is the concentration that we want to achieve and keep in the eye for as long as it's required, where there is bacterial death and no mutation. If we don't achieve a higher than MPC concentration, we are going to get resistance. So this is again the same thing in color. sub-MIC, that is less than MIC, neither susceptible nor first step resistance is there. Resistant mutants are inhibited. So nothing happens. It's above that is the danger zone, because the bacteria are not thriving, but they are mutating. And it's only the green zone above MPC where both the cells also dying, the bacteria dying, and there is no mutation. So what is this? What are the drugs that we use in infections? We have the Genta, Tobra, which are called the aminoglycosides. If you are using this, we've almost stopped using these for simple conjunctivitis cases. If you are using it for keratitis, then you need to fortify them by simply adding 2 ml of gentamicin to the gentamicin drops, or 2 ml of tobramycin injectable into the tobramycin to make 45 drops at 15 milligram per ml, and that would work. And then we have the, we have the fourth generation fluoroquinolones, the becifloxacin, Gatti, Moxi, and these are some of the other ones which are there. Typically, the pharmacology, it works. How does it work? How does it stop the bacteria from progressing? Is that it inhibits the DNA gyrase, topoisomerase 2 and topoisomerase 4. So at 2 points, the bacteria are inhibited. And this is some of the other pharmacology which shouldn't really interest you. So the choice of antibiotics, ideally, there is no ideal antibiotic, but if we were to dream of an ideal antibiotic, it should have the following features. It should be broad spectrum bactericidal. That means it should root out the gram positives, the gram negatives, the P. acnes, the aerobes, the anaerobes, the unusual bacteria like the Mycobacterium cheiloni, fortuitum, all those, everything should be rooted out. It should have excellent tissue penetration, low toxicity. It should be fast acting. And the fourth generation, I told you, the difference between the third generation fluoroquinolones and the fourth is only that the third generation had only one site of action. Either they acted on the DNA gyrase or the topoisomerase 4, while the fourth generation, the Moxi, the Gatti, they work on both dual mechanism. They bind to DNA gyrase as well as topoisomerase 4. So they have, when they came out with, I remember the pharma companies actually saying, "Abhi bacteria ka," in Marathi we say "wat lag gayi." That means that bacteria are doomed now, because now we have found 2 sites where we can, so they can never mutate. Fortunately or unfortunately, bacteria were deaf to the pharma companies. They never heard them. And they went ahead and mutated, so that now we have so much of resistance even to these fourth generation fluoroquinolones. So let's start with the MICs of fluoroquinolones. I told you that the lower the MIC, the better the drug. So these are some of the, so you can see that the MICs are very low for Moxi and Gatti as compared to the third generation. So this slide just to show that fourth generation better than third generation, lower MICs. Now, a comparison of, now we are into the fourth generation. So Gatti versus the Moxi. So Gatti showed 26% higher susceptibility compared to Moxi. And this is for the gram positive. And in the gram negative also, it showed, Gatti showed higher susceptibility. The organism showed higher susceptibility as compared to third generation as well as to the Moxi. Now this study published in the European Journal by the Delhi group, which showed the in vitro susceptibility of bacterial keratitis to the fourth generation. And you see that the most common gram-positive group from the RP center was the Staph pneumoniae and Staph epidermidis. And you see that the green line is the Gatti and the brown yellow line is the Moxi. So Gatti is a little better as far as this is concerned. And when you take both gram positive and gram negative together, even then you find that the Gatti scores a bit over the Moxi. This is a study from South India which studied the spectrum of, because everywhere there is regional differences in the flora that we get. So they found the most common bacteria, 64% was Staph epidermidis and 12.3% was Strepto and only 10% was Pseudomonas. And they, when they checked the susceptibility, again the green lines are the Gatti, it scored over the Moxi. Now, we are talking about sensitivity and resistance. How sensitive, and opposite of that is how much of resistance is there. So I told you that in the 4th generation, there are 2 areas where they block. So in theory, there should be no mutations, but the bacteria are smart. So they have developed what is called efflux pumps, which actively pump the antibiotic out of the bacterial cell. So we are shoving the antibiotic into the bacterial cell, and those fellows have got new pumps to push it back. Our Bombay Municipal Corporation doesn't have pumps to pump low-lying. Our areas get flooded every year for the last 20 years. Pumps to remove that water have not been invented, but bacteria have invented these pumps to pump the antibiotic out of the cell. So there are several ways in which the bacteria prove to be quite smart. And in this study, again in South India with 756 patients with bacterial ocular infections, they found gram-positive was 70%, gram-negative was about 20%. Of course, we know that the fungus is about 30 to 40% in general in India. And they found that the GATI worked better in gram-positive as well as the gram-negative bacilli, and as compared to the Oflox, Cipro, and even to the Moxie. Actually, Moxie is showing much more resistance now because of the widespread misuse of the Moxie. So it's now even the Cipro and Oflox are working better than Moxie in many cases. So this is against gram-negative. This is the MIC90 against P. aeruginosa and Mycobacterium chiloni and N. asteroides. So compared to Moxie, where the dark bars are the gatifloxacin. So you see the lower the bar, that means the less, that's the MIC is less, so it's better. So as compared to the Moxie, almost across all the organisms, the light bars are higher, which is the MIC of Moxie is much higher. So again, this is again and again to repeat the concept of mutant prevention effect. So as I said, the same diagram that you saw, that even if it's below the MIC level, everyone is happy, the organisms thrive. If it is above the MIC but below MPC, then mutation occurs, though the organisms are not proliferating. But if it is above the MPC, even the first step mutants cannot survive. So this is one major take-home message that I want to give you. So you can have MIC 90 and MPC 90, or you can use 50, whatever you like. The idea is that when you look at the next time you're prescribing an antibiotic, they have an insert in the bottle. So take it out, read the stuff which is written over there. You might need magnifying glass or something, but read things like this because it's usually printed, the MIC, the MPC, or look it up or ask the medical rep. He, of course, doesn't know anything beyond the name of the drug. But he will find out for you. He will be thrilled. He'll tell his bosses that you're interested, and they'll give you voluminous literature which you can sell to the Raddiwala after you read it. So the MIC and the MPC values for GATI are lower than those for the other antibiotics. Once you got this, now stop reading the rest of the slides. Just read the lower part. Again, various studies I'm just quoting, least MIC and MPC values against Staph aureus, and similarly, GATI has least against strep pneumoniae. What about penetration? So intraocular penetration after topical instillation, the fluoroquinolones are concentration dependent. The higher the concentration, so a GATI which is 0.5% is better than a GATI which is 0.3%. That is why companies are now switching to this higher, because in 4th generation, it's not true across the board for antibiotics, but it's true for the 4th generation fluoroquinolones that the higher concentration works better. So now I'm introducing to you a new concept. We talked about MIC, MPC. Now we're talking about area under the curve. So what happens is, if you see the graph which is over there, the concentration versus the time. If the concentration is plotted versus the time, how quickly you get the Cmax or the highest concentration. So the quicker it goes in at whatever tissue, cornea or aqueous or vitreous, wherever you're using it, if the Cmax is reached in the least amount of time, that means the antibiotic is better. And if the area under the curve, that means the concentration which is above the MIC level, the greater this area, this triangle that you can see, the greater the area of this triangle, the better it is. So the area under the curve, the more the area under the curve, the better the antibiotic, the less the MIC or MPC, the better the antibiotic. So then that pharma companies dreamt of, why not do a ratio of AUC upon MIC? So you can do that. The higher that number, the better the antibiotic. So area under the curve is an important consideration. So the area under the curve could be area under the MPC curve or area under the MIC curve. So you can see this top triangle over here is the area under the MPC curve, and of course the area under the MIC curve, above MIC, this is always much bigger, like this. But this is the more important, the area under the MPC curve. Now the other funny things, many things they discover by accident, the pharma people, though they take credit for it. Viagra was discovered by accident, as we know, because it was anti-hypertensive, and then people forgot about its anti-hypertensive effect when they found other effects. Similarly, BAK was derided for a long time, that it's a very terrible preservative. It had been used for 40, 50 years, but it was derided. But as far as gatifloxacin is concerned, they found that if you use a minimum dose of the BAK, it actually works in synergy and enhances the effect of the gati. So not that they knew about anything about it, but they accidentally discovered it, that the BAK in the formulation actually enhances the antimicrobial effect, and AUC upon MPC is of course more important than AUC upon MIC. So what is the penetration? Again, just read the lower the concentration of gati. Now we are going into the aqueous humor, was significantly higher than the moxi at the 3.5 hour sample. So what do? They tried to evaluate using collagen shields. They put it there, and after 3.5 hours, they sacrificed the animal and saw how much went into the aqueous humor. And they found that it was statistically significant with p 0.0034. What about tolerability? Gati 0.3 is significantly better than moxi 0.5 as far as tolerability. And Gati 0.5 is also, doesn't show much of any adverse effects, quite tolerated quite well, because you have to put it less times. What about retention? So these are some of the characteristics of an antibiotic. What about retention time? How long is it kept in the eye? So Gati 0.5 was found to reduce bacterial flora more significantly and at a better retention. So if you're using it for prophylaxis, if you want to give it prior to surgeries, then you want it to remain there during the time that you're doing surgery. So if you're doing this 3 days before or 2 days before, then it makes more sense to use Gati rather than moxi. What about speed of action? How fast does it work? So Gati, even 0.3 works better than moxi 0.5 as far as the speed of action is concerned. And it works, it is cutting across all the different isolates, so the staph, the MRSA, which is difficult to treat. So even in all of those, you see that the speed of action, this is the line over here. The speed of action is much faster with Gati than any of the others. So at every follow-up, there were more. Now, I am basically a corneal surgeon. I do keratoplasties. And for me, we normally, when we're doing a penetrating keratoplasty, the epithelium either remove or it gets removed during the surgery. And we are very worried that the epithelium should heal fast. It heals within 3 to 7 days. And at that time, we are putting antibiotics there. So we feel that the antibiotics should not retard the healing. So for us as corneal surgeons, this is very important to know that there were more eyes with complete graft reepithelialization in the Gati group than in the moxi. So I'm reassured that for my keratoplasty patients, I'm safer using Gati because it reepithelizes faster as in the less number of days as compared to the moxi. The dotted line is the other group and the straight line is the Gati group. And the percentage of eyes where it reepithelizes fast within 7 to 10 days is higher in the Gati group. So I told you about Gati with BAK and the presence at a much lower level, of course. It lowered the MPC of the Gati by a significant amount against difficult to treat organisms like MRSAs. So the Gati with benzalkonium enhanced the killing of MRSA strains. And Gatti 0.5% is recommended only twice a day. I never use it twice a day. I at least use it 4 times a day because the bottle has to get over for paisa vasool effect. I'll just end with couple of cases. First of all is that most 90% of our, please understand that the FDA has given approval for all the 4th generation only for bacterial conjunctivitis. We are extrapolating it because the pharma companies tell us to extrapolate and say if it works for bacterial conjunctivitis, it must work for corneal ulcers and all, and it does work. But so 90% of the time you're dealing with viral conjunctivitis, in which case you don't need the Gatti, you don't need the Levoflox, you don't need all these 4th generation. Because what is your aim? Your aim is to prevent secondary bacterial infection, for which chloramphenicol as a bacteriostatic and fungistatic works equally well. Lot of lubricants without even chloramphenicol is also fine. So don't abuse antibiotics by giving it for every red eye or pink eye, no matter what the ads say, pink eye means X drug to be used. So this is a patient who is a 29-year-old computer professional, complained of frequent styes and redness off and on since a month. The current episode was with a greenish discharge and persistent redness since 4 days. So he had actually managed, may have started viral, but he was actually managed to get bacterial conjunctivitis. Again, a pointer that it's bacterial is frequent styes. Styes you don't get with viral, it is usually bacterial. So this computer professional, 29 years old, got this. So what did we do? We put him on topical gatifloxacin. As I said, I use 4 times a day. And there was complete disappearance of the discharge and redness. But don't stop at this. You must treat the patient and not just the redness. So I explained to him about CVS, that underlying he must be having a dry eye, and that causes him or her to rub her eyes constantly with unclean fingers, because when they are sitting 14 to 16 hours on a computer, nobody goes to wash their hands, COVID or no COVID. And this causes the frequent styes, and finally it resulted in acute bacterial conjunctivitis. So if I don't want repeated styes and I don't want bacterial conjunctivitis, I must teach them proper hygiene, correct computer habits, and once my gatifloxacin has done its work, I must put them on lubricants for at least a month and then tell them to use it on an SOS basis. This is a second case, a 65-year-old living alone on anti-glaucoma medication in both eyes, presented with bilateral acute conjunctivitis, redness, watering discharge from both eyes. Cornea was clear, intraocular pressure was normal. Now, it's important to go a little bit into history, because just because it's red eye, we know how to treat. Yes, even the chemist down the street knows how to treat. But the difference between that chemist and us is that we know how to take history. Chemist doesn't have the time that we have, because he's treating peptic ulcers, he's treating gangrene foot, everything is being treated by the chemist. We are only treating red eye, so we have time. So we must chat with the patient. So when I chatted with the patient, I found out that he would almost always touch the glaucoma dropper, eye drop dropper, to the eye, because he didn't want to waste the drop. So he would touch it there and push the drop there while putting the drop. So when they're doing this, the chances of contamination. Normally, any eye drop bottle you can keep for 2 months, 3 months, even if it's not Novella technology. Nothing happens if the patient is careful, closes it well. But this is not a careful patient. So he would never discard the bottle till the drops ran out. So of course I treated with topical Gatti, conjunctivitis improved, but then I explained to him, in his case, the importance of discarding the bottle after a month, not for every patient. And I spoke to his family, I involved his glaucoma specialist. And we made he was on multiple drops, so we made the drops twice a day because the glaucoma was under control, and the family could afford it, so they appointed a caregiver who would go twice a day to his house because he was living alone and put the drops for him. So that was a long-term solution to this. Otherwise, you would have got repeated episodes, viral, bacterial, all sorts of conjunctivitis. So to summarize, antibiotic resistance has become a global concern. We know the concept of lower MIC is better, lower MPC is better. A company which tells you about MPC, you're safer using that product. The resistance to gatifloxacin is the least, the sensitivity is the most. It has the least MIC and MPC values compared to other agents, so showing that it is more potent. It's significantly better tolerated, has good ocular penetration and a faster speed of action than Moxi. And it's a 4th generation with BAK preservative, but the BAK in this case is not corneotoxic and the concentration in which it is there, and it actually enhances the effect of the gatifloxacin. So think differently, and I thank you so much for your attention.
Hello. Thank you very much, Dr. Quresh, for an excellent presentation on the pharmacokinetics of GATI versus the other, and specifically moxifloxacillin. From the audience, like Rishi started, how many of us are using pre-operatively for cataract surgery, any of these two between? I think all of us are. And intracameral? Okay, so intracameral is still okay. Why, Quresh, obviously there is strong evidence to show, as also there is evidence because the resistance is much less with GATI and there is no animal use also of this. So why do you think still there is a resistance to using gatifloxacin? I think Moxi, how many of us use routinely, preoperatively gatifloxacin? None. And Moxi?
I think, see, the issue is marketing many a times. The market leader who brought in the moxifloxacin was excellent as far as the marketing skills are concerned. Even for IOLs, they were excellent. Alcon was, I'm taking names, why should I stop taking names? So Alcon was excellent as far as marketing is concerned. All these companies, when they flood with the advertisement, it does tend to work. I'll give you a simple example in glaucoma. I am a long-term fan of the octopus perimeter. Octopus, when it first came, when it came to India, I was one of the early birds who bought it and loved it because of its baby curve and whatever. But Octopus was at that time a Swiss company and very poor as far as their marketing skills are concerned, while their competitor was Humphrey, which was an American company. 95% of users in the US used the Humphrey perimeter. Every single paper which came out on perimetric was on the Humphrey perimeter. So Octopus was lost. How could they sell when papers were only on the Humphrey? And so finally it was bought over by an American company. And now they are selling a combination, some companies selling Octopus with, means the Octopus and the Humphrey combined in one machine also. So there's a lot to do with marketing. Unfortunately, I feel that moxifloxacin has suffered because of overuse and abuse. It was a good drug at one point, but it's coming down because the resistance is going so high just because every one of us in the audience and on this side are using it so frequently.
So I'm not aware of this latest transaction. I think Octopus is with Hug Street. So it's not an American company.
Hextrite also is, I think...
No. That's a Swiss company.
It's still Swiss. Okay.
Still very Swiss and still poorly marketed and still
Hextrite
sold.
is little better marketing than the Octopus was, but it's still nowhere near Humphrey.
It's all Interziag. So that was the parent company.
I think
Octopus, we are still die-hard Octopus users, at least I am. And I enjoy the machine.
That is slightly digressing from...
I know, but coming back to the Moxi versus GATI debate, I think the thing that switched in favor of Moxi was two factors. One was the fact that it's self-preserved, and they use that in a marketing strategy to try and ensure that we are getting a product which is not having any preservative, without actually highlighting the fact or actually undermining the fact that the preservative can actually be helpful sometimes in allowing better penetration and better tissue listing. So the reason why over the last few years gatifloxacin has started to score over moxifloxacin is that it is being used less. And any antibiotic that is used less comes around in terms of its susceptibility patterns, and the resistance tends to go down. So gatifloxacin has to turn the tables on Moxi to an extent. The other factor that I think went in favor of Moxi was that it is okay for intracameral use. And so as an antibiotic, one would then tend to use it more often intracamerally as well as topically. So I think those were the two major factors other than what Quresh said about marketing?
I think it just starts like, for example, Cipro, Norflox was never been able to take over Cipro. Cipro came and everyone just was Cipro, at least when we were resident. Yeah, go ahead.
There was another point against Gatti. When it was launched, that it masks hypoglycemia.
Orally, you mean?
Yeah, but we are giving it quite frequently post-op. And in 0.5, it may mask hypoglycemia.
No, I don't think quinolones are
Masks.
used that much. Not
Gatric
as a drop.
oxygen masks hypoglycemia.
As an oral preparation.
Yeah, that was
yeah.
there.
But topically, it will not go in enough quantity to mask hypoglycemia. At least I don't have any evidence or any study to that effect. Orally, yes, I agree with you.
And somehow I think psychologically we are always used to more than BD dose. Anyway, I think Bharti, one last comment and then we go on. And you can also tell what is the score.
I can always tell, yeah. The one important fact is that majority of us are using topical Moxie and using the same for intracameral. So I think that is not done, that is not a good idea to use the same antibiotic 3 days, 2 days, whatever before, and then put the same thing intracamerally. So one should, either not use Moxie as an intracameral when you're using a Moxie preoperatively, or maybe you have to change the preoperative medicine and then use it as a intracameral.
Yeah, but I think there is a very little difference between then you should go to a separate subgroup rather than using Gatti and Moxie.
No,
You have to,
not the fluoroquinolones at all.
Not.
Yeah.
Okay.
No.
Thank you very much. I think we'll go on to the final topic of the day. Dr. Virender Sangwan was unable to come because of some medical emergency. So I'll request Dr. Rishi Mohan to talk about the cyclosporin, I would say, for dry eye state. And Rishi, as we all know, is a great corneal surgeon and is chief of MMI Tech. And he'll be talking about the treatment of inflammation in dry eye. Rishi.
Thank you very much, Mahipal. Actually, I am filling in for Dr. Virender Sangwan, who was supposed to have presented this, but he's unable to come and make this presentation. So I've been given these slides, and the reason I'm actually showing these is that before we get into a panel discussion on the subject, I thought it would be appropriate to at least have the audience and the rest of the panel on the same page. So I'm very quickly going to introduce these slides. So the topic is to treat inflammation in dry eye. And as we all know, over the last almost 2 decades now, this is a subject that has caught the fancy of everyone who treats dry eye. And I think it has percolated down now even to the general ophthalmologist, that there is inflammation as an important byproduct of a dry eye. And very often the inflammation and the dry eye actually feed off each other. And strategies have naturally evolved to try and ensure that we have a treatment for dry eye. This is a slide that I'm sure we've all seen ad nauseum, which is showing the key mechanisms which perpetuate the dry eye vicious cycle. And we know that tear film instability, hyperosmolarity, apoptosis, which is of course at the end an inflammation, feed off each other and perpetuate this cycle. There are lots of extraneous factors which contribute to this cycle, and these are then have to be looked at individually, and inflammation being one of the key mechanisms is what we're going to address today. So it's a physiological response to invading pathogens. Inflammation due to infection or injury can result in ocular inflammatory disease, and excessive inflammatory responses can damage healthy tissues. So these are the consequences of inflammation in DED. These are just standard things. They are tissue destruction, which is again apoptosis. They are neurosecretory blocks, which are mediated by inflammatory cytokines. And these chronic neural damages lead to a host of other effects. And along with the inflammation, and as it goes beyond the acute phase, where it is driven more by the chemical mediators, it eventually goes into what we call T cell activation. So there is a secondary cascade of inflammation that starts to happen a little later when the inflammatory process has begun or hyperosmolar damage has started to happen. And this T cell activation causes an influx of calcium into the cells. These again lead to a reaction, and the nucleotides inside the nucleolus are actually dephosphorylated, enter the cell nucleus, and then there is a transcription of genes which are involved in the immune response. So the cytokine activation and dry eye disease causes an inhibition of neural stimulation and destruction of the glandular structure. There's disruption of nerve cell function. There's production of adhesion molecules, which then again will add to a cascade because you have inflammatory cells which actually come into the sites and add to the inflammatory process. MMP9 is one of the matrix metalloproteinases which is known to get upregulated when there's inflammation. And this, whenever there is a stress in the ocular surface epithelial cells, there is an increase in MMP9. And the reason I think this has been brought up in this slide is because we now have a methodology which can actually measure MMP9 levels in the tears and tell us whether there is a significant amount of inflammation or not. So patient symptoms, I don't think we need to go into this. No, I think this is just pretty standard stuff. So this is inflammation may not be initially evident, which is a fair enough comment and is often overlooked. And a thorough medical history and the noting of the patient's symptoms, I think it's been highlighted. I think it applies to anyone who comes in with a red eye. And as Quresh had aptly said, chemists don't have time and we do. And so we must assess the other aspects of the eye as well, like the visual function and the light reflexes, etc., to see whether there's anything else going on. Then to do the order of the diagnostic test. So naturally it stands to reason that anything that is non-invasive should be done first. Get a history, get an OSDI score, examine the face, and do a slit lamp examination. Look at the, just by looking at the slit lamp, you can look at the tear meniscus, you can look at the reflex from the cornea, you can see the lack of luster, and that gives us a lot of information. Then, of course, we go into the invasive tests, such as the tear breakup time, which again can be the non-invasive breakup time. The ocular surface staining would then be a very, very important tool to help us decide the level of the kind of dryness and the spread of the dryness. A Schirmer's test for aqueous deficiency, and then of course inflammatory marker testings for MMP9, HLA-DR, and I think you can also throw in here hyperosmolarity, which would be another assessment for dry eye disease. So I think these are pretty much standard stuff. You put between fluorescent and or lissamine green and the rose Bengal. That's just about the only debate. Fluorescent, I don't think is really helpful other than in the severest form of dry eye where the cornea gets involved. My own preference is for lissamine green because it is readily available, it is less reactive, less irritant as compared to rose Bengal. Schirmer's test measures the tear volume. It can be performed with or without anesthetic. Generally, the one performed with anesthetic is more sensitive and more specific for dry eye as compared to if you don't put the anesthetic, because when you don't put the anesthetic and you use a Schirmer, it is the reflex tearing also that is being measured. And when you're measuring reflex tearing, you're actually not really testing for real dry eye. So we used to do Schirmer's test as a routine. We've stopped doing it. After almost 20 years of doing Schirmer's testing, we decided that it's not something that really gives us much value and just takes time. So we only do it now in the patients who we think have a moderate to severe dry eye disease. This is the MMP9 test for inflammatory markers. I'm not sure if anyone is routinely using it in this room. Anyone routinely using MMP9? No. So inflammatory markers, it's quite expensive as well. So we don't really use it. We're still using other tools to try and diagnose inflammation. Impression cytology, again, is by far the gold standard in a sense, because it will tell us about what is happening to the cells. Again, more not in the clinical realm. Standard therapies for dry eye disease are naturally education, environmental dietary modifications, and lubrication, of course, will always remain the mainstay. But patients with moderate to severe dry eye should be considered for anti-inflammatory therapies. And these are the summary of the anti-inflammatory therapies. We have cyclosporin, steroids, oral macrolides and tetracyclines, omega-3 fatty acids. There's serum or autologous serum for the more serious disease, cytokine inhibitors, TNF-alpha inhibition, and then, of course, the mainstays of artificial tears. There's surgical methodologies as well, such as punctal occlusions, and the use of secretagogues. So steroids, tetracyclines, and macrolides have significant risks associated with long-term use, and to address inflammation, cyclosporin has become the mainstay just on account of its safety profile. It may not be as effective as the others, but it is certainly a much, much safer drug. It was approved by the FDA in 2003. The potential mode of action is it's a T-cell inhibitor and inhibits leukocyte migration. It inhibits the pro-inflammatory cytokines and the activation of the APCs, and protects the epithelial cells from apoptosis. So if you remember the first chart that I showed you about cyclophilin, the cyclosporin A binds to the cyclophilin and doesn't allow the calcineurin to get activated, which then stops the T cells from activating, which don't proliferate, and there is therefore the immunosuppression. So here are some clinical studies, I think, where there is showing the mean changes in the Schirmer score from baselines at the start of the process, and then at 3 months and at 6 months, and one can see how cyclosporin has substantially improved the Schirmer score. And one can see that the cyclosporin 0.1% and 0.05% have a very slight difference in their efficacy, and that's why 0.05% actually was the one that got picked up as the standard of anti-inflammatory care, because the 0.1% had many more side effects than the 0.05. The same thing applies to the TBUT in mild, moderate, and severe disease, and in the fluorescent staining scores as well in mild, moderate, and severe disease with and without this product in use. So the Schirmer's test score in a study in which I think they did a crossover trial where they used cyclosporin, and then they switched to, after the cyclosporin had been used for a while, they stopped using the cyclosporin and switched them back to conventional tears, and you find that there was a reversal in the benefits that had been accrued over time. Cyclosporin O also reduces the ancillary drug use. So as the inflammation goes down, there would be a natural reduction in the use of other products that may be used by the patient, including steroids and including the quantum of the lubricating drops. So the treatment plan is twice a day, 1 drop per eye. The effects don't start immediately, and that's part of the counseling that one needs to do. Durations can be very long, can be lifelong as well, and recurrence of signs and symptoms can occur within the year. So patient education is extremely important. These patients have to be counseled that what they're dealing with is a chronic disease, just like maybe their hypertension or their diabetes. The problem isn't going away, and you need to continue to use these drops for a length of time. It can be used in conjunction with artificial tears. Steroids can be administered alongside cyclosporin A at the beginning of the treatment, and this is something that I think we all pretty much follow now and has become fairly the standard of care again for patients with dry eye. It does help to improve these patients faster. Their confidence in the treating physician improves because they start to see a response faster, and then the local steroid can be tailed off, allowing the cyclosporin to continue the benefit. So patients whose tear production is suppressed due to ocular inflammation associated with dry eye disease is where the indications of cyclosporin are. Goblet cell density also improved with cyclosporin use. I think these are just studies from the literature. So this is important to understand that the patient education is extremely important for the success of cyclosporin. We do not often inform the patient that this medicine will take time for the benefit to happen. And unless that education is provided, the compliance drops, and when compliance drops, the efficacy drops, and the patients get disheartened and stop using the product. So patient education was essential when repeating treatment with cyclosporin, and they should be informed that there are common adverse events such as stinging, which reduce as time goes on, and the clinical improvement is achieved in 80% of the patients who were part of the PERSIST study. So patient compliance, whatever this is. Okay, we'll go on. So inflammation is one of the 4 key mechanisms of dry eye disease. Stimulation of inflammatory mediators results in a positive feedback loop. An examination of the various aspects which we've just highlighted are important for diagnosing the inflammation. There's a wealth of therapies for treating inflammation, including artificial tears, antibiotics, cytokine inhibitors, serum, steroids, and cyclosporin A. But cyclosporin A is effective at reducing the signs and symptoms of dry eye disease with no serious adverse events. And I think that's by far the most important aspect of cyclosporin A. Case studies. Do we need case studies? So here's a patient who has already a moderately severe disease, fluorescein staining at 4+. So ANA antibodies, SSA antibodies are positive. So the patient of Sjogren's, you can see the amount of staining that is there, right? In this area, you can see the amount of staining. Schirmer's test without anesthetic is 1 millimeter. So that tells us how dry this patient is. What happened? Okay, so yeah, so there's primary Sjogren's syndrome, and the doctor had prescribed non-preserved artificial tears 6 times a day, loteprednol twice daily for 10 days, 2 drops once a day, then for 10 days, and 1 drop once a day for 10 days. And Restasis, which is cyclosporin A 0.05% twice a day for a year, along with some omega-3 at 1 gram per day, and some HCQS at 200 milligrams twice a day. So this was a combination, I think, between the ophthalmologist and the rheumatologist where this kind of treatment was given. Fairly appropriate, I think, given the severity of the disease. And of course, I'm sure, as you can see, the loteprednol was tailed off and allowing the other drops to continue. A year later, the symptoms had almost disappeared. The Schirmer's had improved. Lissamine green staining had reduced to 1+. The fluorescent staining on the cornea had gone, and the patient was continued on Restasis and unpreserved artificial tears. So the second patient is a 65-year-old, is rheumatoid arthritis, already being treated with methotrexate, and the current therapy was unpreserved artificial tears with only partial relief. So the visual acuity was normal, conjunctival hyperemia, tear breakup time was only 3 seconds, fluorescent staining was 3+. The patient had a mild floppy eyelid syndrome as well. Okay, so the interpalpable staining with lissamine green, and of course, we all evolve our own scores, and I think that's a healthy practice to do. We must evolve our own scoring pattern so that one can then have the consistency when you re-examine the patient to be able to see whether there is an improvement or not. The Schirmer's test without anesthetic was 2 millimeters. So this was a secondary Sjogren's because the patient's already a known rheumatoid arthritis patient. So what did they do? They were using non-preserved artificial tears. They added sodium hyaluronate, and fluoromethalone was used instead of loteprednol here, TDS, then BD, and then OD. And again, Restasis, artificial tears gel in the evening, and omega-3 and methotrexate was ongoing once a week. Oh, there are more? Okay, so this patient is, again, a 60-year-old lady with rheumatoid arthritis, again being treated with methotrexate and adalimumab. And a current therapy was unpreserved artificial tears, hygiene, short-term fluoromethalone. So what happens, I think, over time with these dry eye diseases that they start to involve the meibomian glands, and there will then be a spillover effect where MGD also then becomes a feature. Restasis or cyclosporin A is effective to control inflammation, even as far as the meibomian gland disease is concerned. So there is a role for using cyclosporin even in MGD patients. Again, significant amount of this thing. So here they've done osmolarity was 322, which is significantly high. Schirmer's test was again 1 millimeter, and there was lissamine green staining. So the diagnosis here was a chronic aqueous deficient dry eye disease, and the solution that was being prescribed was non-preserved tears. Notice that non-preserved tears have become the mainstay pretty much everywhere. We still don't have enough of them available to us. Unpreserved dexamethasone. So you can see that the strength of the steroid is going up as we go into more and more severe patients. Autologous serum has been added here, QID, for 2 months, along with cyclosporin A, artificial tears gels, and punctal plugs were inserted in both inferior puncta after 6 months. Why did they wait 6 months? Anyway, and omega-3, 1 gram per day. So 2 years later, symptoms were much better. Schirmer's had improved, lissamine green staining and fluorescent staining had resolved, and the unpreserved artificial tear drops were being used 3 times once a day. So just to give you a brief overview over this presentation, and I think we can, or maybe I should start asking the questions, is it? That's the first question is to Dr. Bharti, who will tell us what the score is. The score. Okay. We're going to go on, and let me see what questions.
Let me give you the score. It is 114 for 6 Pakistan playing, and 7, yeah, 114 for 7. Everyone is, they're more keen on this score, so let us finish the...
Thank you. Thank you, audience participation. Who said that? Who gave the 7th wicket to us? There's a sweet from the dais. Okay. So we'll
Rishi, one question to you. The first case that you showed, obviously in that you had said about systemic chloroquine. Why do you think we are not using topical chloroquine, which is available in India? I think, is there a paucity of results? At least I use it reasonably significantly in the cases. It's a cheap drug. It comes as UV lube. And chloroquine, as you all know, we exported to entire world for COVID. That's a separate thing. But I think the chloroquine is now a standard of care for patients with connective tissue disorders systemically. So has anybody...
Yeah, I share your enthusiasm for the topical chloroquine, and I use it quite a bit. One good thing is that it doesn't interfere with your restasis, or it doesn't interfere. There are 3 drugs, topical drugs, which are anti-inflammatory. One is trehalose, one is topical chloroquine, and the third is the cyclosporin. And this doesn't interfere, so you can use even combination of any 2 of these along. So most of your trehalose comes along with part of lubricants. So you can use trehalose containing lubricant and UV lube, or you can use restasis and UV lube. I find that patients who have got photophobia as a symptom, where they shun light, they can't open their eyes, they are the ones who somehow in my hands do best with UV lube. So anytime a patient comes to me with dry eye and presenting symptom is photophobia, or in my clinic he gives me a history of photophobia, 110% he is going to get UV lube. See, restasis you can use for 5 years, 10 years, there's no problem. UV lube, if you're using, you use it for 2 months max, then give a break for a month, then again you can use for 2 months. So you don't abuse, because little toxic if you use it for beyond 2 to 3 months at a stretch. So I typically use it for 2 months, have a washout period for a month, and then may put him again on 2 months.
So the company suggests only for 20 days.
Yeah.
And then they don't want to continue for a while.
Yeah, because they're scared. It is a little toxic in the long run. Yeah.
This is why majority of times the symptoms do not get resolved.
I use it up to 2 months, I found not a problem.
Then 20 days down the line,
It's too little.
Stop. Yeah, it is too little actually. So their strategy has to change on chloroquine prescriptions. That is the problem.
Why this chloroquine is not helpful systemically? Because we use topical medication of the chloroquine, but when you take it systemically, it doesn't help for the dry eyes.
No, it does help as far as the anti-inflammatory component is concerned. The problem is the side effects do not warrant its use in routine dry eye. So unless the dry eye is driven by a systemic anti-inflammatory component such as rheumatoid arthritis or any one of these collagen vascular disorders, there is a role. Otherwise, for a pure dry eye, I wouldn't suggest systemic use when there is no systemic comorbidity.
But most of the patients,
topical chloroquine and HCQS are different in terms of their efficacy. What we're giving topically is chloroquine. What we're giving systemically is hydroxychloroquine.
Yeah, definitely, because the efficacy is different, but the basic action is same.
Yes.
So whether it's hydrochloroquine
Correct.
or the chloroquine,
But the
basic action is same.
It's the toxicity that's the problem.
But many of the patients, those who are already on chloroquine systemically, especially the rheumatoid arthritis or other immune disorder cases, we don't see any any benefit for the dry eye because they come up with a lot of dry eyes and then we have to shift to the other medication also.
See, what happens is that the rheumatoid arthritis, the disease process rheumatoid arthritis is a pan-body process. So it affects our SNR, the cells of the aqueous producing cells are affected very, very strongly. And the systemic hydroxychloroquine works to some extent in the body, but has not so much of an effect on the SNR cells, while the topical chloroquine works a little better because it's targeted.
So it means the penetration topically is better than the systemically to
Very
the
much. Yeah, because
SNR
the
cells.
systemic hydroxychloroquine, the dose you will require to have a good penetration in the eye will be a very toxic dose. This is what I feel, because even when first of all, I never prescribe HCQ to a patient. I normally involve an internist just because of the toxicity. I am happier prescribing methotrexate. I don't use an internist to prescribe methotrexate. Many of my patients are on methotrexate if they have got some issues, because it's a once a week drug which is fairly well tolerated. You can give between 10 to 15 milligram once on Sundays, or you can give Saturday, Sunday, split it up into Saturday, Sunday or something like that. And they can go for months together. But HCQ, I'm a little worried because of the side effects.
And second important point which I want to ask is oxytetracycline. And we have been giving oxytetracycline for the meibomian gland disorder, especially like when you have the lid disorder. And it's being taken as systemically, basically. So do we have any provision to put it topically, topical drops or?
No, I think the problem again is that it's not water soluble. And that is one of the problems with the entire tetracycline group. It has to be given in an ointment form. The other thing is what's most effective is actually doxy. And we don't use it as an antibiotic, we use it as an immunomodulator because that's its other effect. And that's why the dosing is very different from tetracycline given as an antibiotic. So if you go back 15 or 20 years or 30 years even, when tetracycline was the antibiotic being given, it used to be given QID, and it used to be 4 to 5 times the dose that we are currently using for an antibacterial effect rather than for a immunomodulator effect. The other point that I think was brought up was about the anti-inflammatory medications that are available. So tacrolimus is the one that actually will fill the space better than Restasis, especially if there is somebody who is sensitive to Restasis. And there are a few people who are allergic, and their tacrolimus is very useful. Trehalose is a sugar and works more through the osmoprotective action rather than an anti-inflammatory effect, which is indirect. So if you're looking at a list of anti-inflammatories, you would then go through cyclosporin, tacrolimus, which are very similar calcineurin-based inhibition. And then we have chloroquine, which is a relatively newer product. And there's a lot of work that has been done at RP Center. And so they restricted most of their work to 4 weeks. So the data beyond 4 weeks is all anecdotal. 2 months, as Dr. Quresh suggested, is I think a reasonable compromise. I also prefer to take them off by that time, hoping that the anti-inflammatory effect would have got established. And the two can be given because they may have a synergistic effect. So there are patients with the moderately severe dry eye who will receive both cyclosporin and chloroquine as well, and of course preceded with a short course of topical steroid.
I think, Rishi, even today, dry eye disease is relatively underdiagnosed. I think the use of cyclosporin again is slightly less than I would prefer, because the point is that you should use cyclosporin earlier in the disease rather than later in the disease, because that's the time when the cycle is setting in and things like that. So that is when, and I as a routine also use it for post-refractive surgery patients. So, and then they need to be given for a longer period of time, because you really don't have any effect of the cyclosporin coming in early in the, this thing, maybe in a month or two. The slide actually which you showed, which showed between 3 months and 6 months, you could see that the Schirmer went up much, much better when you were using it for 6 months. So I think from that, and again from a synergistic effect, when you rightly said that meibomian gland dysfunction can also be, so it could be both of them running in together, and the new things that you are getting for MGD, apart from the use of doxy that you are saying, or erythromycin also, is the IPL or the LipiFlow, etc. So I think those are the things which can also be added, because dry eye is a very troublesome disease. And it is significant in, as the patients keeps on aging, especially post-menopausal women, etc. So you have to actually analyze, and maybe the youngsters, would you wish to say something, because there's a lot of work that's being done in NN on dry eye. Anything new which you would want to say?
Rusha?
That trehalose actually acts on autophagy. That's the mechanism by which trehalose acts, and that's how it prevents dry eye. But I agree with sir. I think other things like LipiFlow and IPL do help in therapy. I think NN is working on some kits for diagnosis more than on therapy right now, per se. But those are more diagnostic kits for other inflammatory markers that they're looking at.
So I think we've all been through 2 years of a pandemic. What would be the opinion of the House? Did we actually see an upsurge in dry eye patients? What do people think was compared to 2 years earlier? Did we actually see more dry eye in these 2 years than we saw in the previous 2 years? We did? Did anyone try and analyze why? Screen time? So was it restricted to a younger age group, or did we see it across all ages? Younger children are having more dry eye. So
Rishi, even the face mask is supposed to cause this. There's a special name now added to this.
Of course. MADE. Yeah, that's called the mask-associated dry eye, which is a syndrome which is being described, MADE or MADE. So yeah, that is, it's actually the carbon dioxide that is being exhaled, which is actually being absorbed by the tear film, creating an acidic environment. And it is creating an inflammatory component which adds to the dry eye in these patients. So, yeah, that's an interesting aside due to COVID that we've all seen. So yeah, I think we've all seen that increase in dry eye patients coming from the younger age group, but that could also be asthenopia, because they were spending so much time on screens that it could be a convergence issue. So they come with this vague discomfort, these young kids.
Sir, most of the kids who are coming for the first time after the lockdown, they're landing up with high refractive errors indeed. No error earlier, but now landing with -3, -4, equivalent cylindrical, all of a sudden.
So what actually is, I think my personal feeling is that it's not as much what has actually got created, is that there's been a cluster effect. So for 2 years they were underdiagnosed. They were not going for their tests. They were not going to school. They were not being given distance screens to look at. They were being underdiagnosed. So they've just suddenly come as a cluster. Schools opened, suddenly they found half the kids can't see the blackboard. So this would normally have been a trickle, and one would not have realized this kind of numbers happening. Schools would have routinely sent them in little batches, rather than when they all went together and found that, 10 kids in every class can't see the blackboard.
More than that.
Yeah, well, 10 more than what it was. So yes, 50% of children need glasses on average, and I think if you walk into any school and you see less than half the kids wearing glasses, there's a bit of underreporting happening.
No, but I think the incidence of myopia has gone up with the COVID, and that's a global phenomena, and there are studies out of Far East and China which is showing a 2% increase in the incidence of myopia. But I don't know how many of you are aware, but there's a lot of work that is now commercially available. You have these glasses that have been introduced by Essilor, Zeiss and Hoya, the three companies which actually help in reducing the progression of myopia. So what they do is that they stimulate the peripheral retina, and that causes a reduction in the increase in the, and they're not too expensive. So we just about starting that, and I don't know, a lot of you, how many of you, atropine has become pretty much good, I think it's working pretty well. So these are two things that are happening because there's a lot of work that's being done on myopia control. And obviously dry eye with computer vision syndrome is something which is increasing.
Yeah, so just to give you from personal example, my granddaughter at the age of 7 developed myopia, and she is wearing these glasses. They're not from Essilor or where, this Chandrasekhar Chavan makes them in the US, so I got them from there.
So, but is that also on the lens slit basis?
Yeah, yeah. So the central area is the myopic -1, and the periphery is a +5 hyperopic defocus, so that it prevents the blur, and it allows the rays of light to fall inside and not behind the retina. The issue with this is the compliance. So my granddaughter obviously doesn't listen to her parents, but I up to now thought that she would listen to me. Doesn't happen like that. So whenever she's on the screen, she doesn't mind using these glasses, because at that time she's not moving her head. She's staring at the screen. So that central myopic area is fine for her. But if she's playing games or something, she doesn't want to, because they tend to move their eyes to the periphery, and then the vision is a little blurry. So I don't know how we're going to convince them to use it more often. So she uses it only for the screen. And it's still, I've just been about 2 months since I've prescribed, so I'm going to check her again after another couple of months to see what's happening.
Yeah, but they say that there's an adaptation time also.
Yeah, yeah. So,
and we're all using low-dose cycloplegics for the progressive myopes. Is that become the standard of care now as well?
Using what?
Low-dose
atropine. Yeah. Absolutely standard of care. For progressive myopia, I don't give it on the first instance of a myope child coming to me. I call them after 6 months, and if there is a progress of greater than 0.5, then I'll put the patient on low dose.
Fair enough.
Atropine. Yeah.
So I think we've had a fantastic discussion, some on the subject and some as required. So thanks everyone. Thanks very much to the panel and to Alagan again. And we'll invite them back to give us their concluding remarks.
Thank you everyone. Thank you delegates for joining us on a Sunday evening. And before closing this event, I just want to special thanks to our eminent speaker, Dr. Rajendra Prasad and Dr. Grace Matsukati, for making this event more insightful and more interactive. And I would also like to acknowledge and thanks our panelists, Dr. Maipal, Dr. Sudhang Bharti and Dr. Rishi Mohan for sharing their insights and making this meeting more interactive. And in the end, I would like to request you all to join us on dinner, and the bar and cocktail is open. Thank you, sir. Thank you, sir. Thank you. Thanks a lot.